Good afternoon, good morning, or maybe at some places, good evening. It's a pleasure to join the initiative by Apostle led by Dr. Lau on the best papers in Hepatology International. And one paper which has been picked up is on high normal alanine aminotransferase as an indicator for liver histopathology in E minus chronic Hep B. And this is by a group from China by Dr. Duan, Dr. Shi Xiao, and Dr. Liu and Dr. Zhuang. I am not sure if any one of them is here. George, are any one of them being invited?
Yes, they have the pre-recorded the presentation.
Pre-recorded. And I
Yes.
also would like to welcome our president, Professor uh, Will, and also Philippa Easterbrook from WHO. Thank you both for joining. While we are starting with the recorded message, I want to give you some important data on this topic. So, way back in 2008, we published a series of about 1,500 patients, of which the category was of three types. One was those who had raised ALT, those who had intermittently raised ALT, or those who had normal ALT. E minus, normal ALT were about, if I remember well, 83 or 100 patients out of the total 1,500. Those patients who had E minus and normal, persistently normal ALT, in them, the liver biopsy changes were seen in roughly about 1 in 5. But if there was intermittently raised ALT, the biopsy changes had reached up to 38% or so. And these people also had raised HBV DNA. So it was the first paper, and subsequently two more in gastroenterology, 2009 and so, where we said if you have normal ALT, it does not matter, and liver disease can still go on. And also that a half normal at that time, 20 was, 40 was normal, and we took half. Even if you take half normal, there is liver disease. Now, if you have raised ALT, there is no doubt in E minus that you will have injury. And several subsequent studies have come. Now, this study by Dr. Duan certainly tells us, and it is corroborated by another paper which came in Lancet Gastrohepatology in probably February 2024, that if you are E minus with raised ALT, the disease is much more compared to those who have E minus and normal ALT. But normal ALT does not exclude, and still you have a significant number. So the questions which we will have after the recorded message, but this was the background I wanted to, set the ball rolling. And thank you, and we may start, and then we have comments from other experts. George, are we going to hear now the recording?
Yes, Ishumi, can you put on the presentation?
Okay.
Good afternoon, dear professors. It's my honor to speak here, and I am very glad to share my topic with you. First of all, let me introduce myself. My name is Menghui Duan, major in pathogenic biology, graduated from the Department of Microbiology and Center of Infectious Diseases, School of Basic Medical Sciences, Peking University Health Science Center. What I am going to talk about today is high normal alanine aminotransferase is an indicator for liver histopathology in HBeAg negative chronic hepatitis B. My report mainly includes the following parts: the background, the purpose and methods of the study, and I'll discuss the results. So let me start with some general information on chronic hepatitis B virus infection. Chronic hepatitis B virus infection is still a considerable problem affecting the world public health. It is estimated that the present prevalence of HBsAg in the general population in China is 5 to 6%, and approximately 70 million people infected with chronic HBV, of which about 20 to 30 million are chronic hepatitis B patients. Owing to the largest population in China, eliminating the threat of hepatitis B in the future is still a huge challenge. And then, let's briefly mention the natural history of chronic hepatitis B infection. The natural history of CHB is commonly divided into several phases: immune tolerant, immune clearance, inactive carrier state, and reactive phase. HBeAg negative CHB patients with persistent normal ALT and low HBV DNA levels, which means less than 2000 IU per milliliter, are usually defined as inactive carriers, which also called low replicative chronic HBV infection. Those patients having no or minimal liver injuries. Therefore, antiviral treatment for these patients is generally not recommended by most international practice guidelines. However, recently, more evidences have shown that HBeAg negative patients with persistent normal ALT levels have significant liver histological changes which can count for 20 to 49%. So it is imperative to identify true inactive carriers. In our study, we aimed to investigate the prevalence of significant liver histopathology in HBeAg negative CHB patients with normal ALT and determine association between significant liver histopathology and age, ALT levels, and HBV DNA levels, so that we can look for clinical indicators that can predict or indicate significant liver histological changes in patients with chronic hepatitis B in the inactive phase. After introducing the research background, the inclusion and exclusion criteria are described on this slide, and I won't go into too much detail here. So, with those purpose, 2,063 patients who underwent liver biopsy in Guangdong Provincial Hospital of Traditional Chinese Medicine were retrospectively analyzed. As shown in this flow diagram, finally, 327 patients were included in this study. At the same time, I would like to mention that APASO guidelines recommend that ALT level is divided into the high and low normal ALT. So we evaluated the liver histological grade of all patients categorized into different ALT, HBV DNA, and age groups. And now, let me come to the results of the study. Among 327 HBeAg negative CHB patients, 132 patients had a low normal ALT, and 195 patients had a high normal ALT. There was no significant difference in age between low and high normal ALT groups, and the high normal ALT group had a significantly higher BMI, HBV DNA, and GGT levels compared to the low normal ALT group. Besides, the proportion of significant liver necroinflammation and fibrosis in the high normal ALT group was significantly higher than that in the low normal ALT group. The percentage of liver damage reached to 44.6% versus 26.5% and 61% versus 41.7% respectively. When we further combine the analysis with age, we found that whether the age was less than 40 years or greater than 40 years old, the high normal ALT group had a significantly higher proportion of significant liver necroinflammation and fibrosis than the low normal ALT group. Besides, we also analyzed according to different HBV DNA levels and the proportion of significant liver necroinflammation and fibrosis in patients with HBV DNA more than 2000 IU per milliliter was significantly higher than that in HBV DNA less than 2000 IU per milliliter group. When comparing the low and high normal ALT groups, we discovered that the proportion of significant liver necroinflammation and fibrosis in the high normal ALT group was significantly higher than that in the low normal ALT group, while HBV DNA level was less than 2000 IU per milliliter. Except for those subgroup analyses, I would like to draw your attention to next slide, which we carry out univariate analysis and multivariate logistic regression analysis to examine age, sex, ALT, and HBV DNA levels as potential independent predictors of significant liver histopathology. As described on this slide, Spearman correlation analysis revealed that there was a close positive correlation between liver necroinflammation and ALT and HBV DNA levels. At the same time, ALT and HBV DNA levels were also closely positive correlated with liver fibrosis. However, association between age and liver histopathology was not found, as well as sex. And then age, sex, ALT, and HBV DNA were further analyzed by multiple logistic regression analysis to search for predictors of significant liver histological changes. ALT more than 20 U per liter was an independent predictor for significant liver necroinflammation and fibrosis, and as well as HBV DNA more than 2000 IU per milliliter. At the same time, we observed that female is also a predictor of significant liver necroinflammation, but not of liver fibrosis. Therefore, let me briefly summarize the main issues. Our study demonstrated a considerable proportion of HBeAg CHB patients with normal ALT had significant liver histological changes, and even 46.2% of patients with normal ALT and low HBV DNA levels had significant liver fibrosis, which implied that inactive carriers may have active liver disease. For HBeAg negative CHB patients, ALT more than 20 U per liter and HBV DNA more than 2,000 IU per milliliter are both good independently predictive factors for evaluating significant liver histopathology. Normal ALT and low viral load may not be sufficient for confirming no liver injuries. The management of HBeAg negative CHB patients with normal ALT should be considered prudently. Liver biopsy or non-invasive methods are suggested, and to treat the patients who have significant liver histopathology. That's all what I have reported today, and thank you for listening.
Thank you very much. I hope you are online somewhere listening to our comments. This is an important study and a very large group of patients and very well conducted. And you have Professor Lou is here, mingling you. Very nice to see you. This study is a very important study, according to me, and it reaffirms a very important message that people who have got normal ALT do not necessarily have a normal liver with hepatitis B infection. Number two, HBV DNA of less than 2000 does not mean that the person is not suffering. The third part is we call the term as chronic carrier. Carrier is a person who carries the infection, can transmit the infection, but does not suffer. Here we see that people who would otherwise have called HBV carrier are themselves transmitting, can transmit. Two, they also are suffering from disease. So the term chronic carrier was in a way buried long ago in 99, and we feel it chronic HBV infection. So first message from my side on this study is that chronic HBV infection with normal ALT and HBV DNA less than 2000 does not safeguard you. We should not ignore, and as rightly concluded, these patients should have possibly a liver biopsy or a non-invasive test. The current guidelines, even the best new guidelines by WHO, do not recommend that we should do a test or a biopsy in them. And therefore, it brings us back to the basic thing that should we treat all rather than treat select? Because by treating select, we might miss a large proportion of E minus with normal ALT and less than 2000 DNA. So I compliment the authors and I feel that these patients should not be ignored. And I would now leave it to Philippa to give her comments and then pass on to Professor Lau. Philippa.
Thank you very much, and congratulations to the authors. And I think, as Professor Sarin has commented, this is adding to the growing literature on the natural history and outcomes in those with low viral load and normal ALT. And I think this is confirming what other recent studies have shown, that the presence of significant necroinflammation or liver fibrosis in this population. I think we have also done a recent systematic review that informed the WHO guidelines, stratifying by both the ALT and by the Hep B DNA. And while the risk of progression to clinical events, cirrhosis, HCC, and liver-related mortality was much, much lower in those with normal ALT or less than 2,000 hep B DNA. It is not negligible. It is not negligible. And I think this study that showed that intermediate endpoint of the development of significant fibrosis is key. I would just like to pick up on 2 points. First of all, the definition of the upper limit of normal. WHO back in 2015 established we adopted the 30 units per liter for men and 18 for women. And we have in the recent guidelines extended that to adolescents, both the 30 for men and boys and 18 for women and girls. We know that some others have defined thresholds for adolescents being different, less than 25 for boys and less than 22 for girls. And I think it was notable that 40 was the threshold defined in the lab. And then it was broken down into the less than on greater than 20 units below. So I do think having clarity on the normal level, and certainly the one that we are promoting globally, is the 30 and 19. We did that for both adolescents and adults, even though the adolescent data suggests a different threshold. For simplicity, we adopted the same. And I think there's a need for more work to be done in the area, in different regions and populations, being clear about the appropriate upper limit of normal. I also wanted to just comment on the non-invasive tests, because this is something that's center stage now in the new WHO guidelines. We are actively promoting that all persons should have a non-invasive test, an APRI score, which of course requires our basics tests, which are widely available even in low and middle income countries, or transient elastography if that's available. And if there's present a significant fibrosis, so greater than or equal to F2, then treatment is indicated regardless of hep B DNA levels or ALT levels. So I think that is an important message. That's just one of the 4 options for meeting treatment eligibility. And this speaks to the findings from this study that there is presence in a significant proportion of fibrosis in those with normal ALT or low hep B DNA levels, and therefore having that common pathway of assessing everyone and staging disease, not requiring liver biopsy, but use of non-invasive tests will be the fast track to treatment. And I notice actually the mention of non-invasive tests is just in the last paragraph or sentence of this. So I think those are the main messages, but I think the imperative in future research to really further finesse the definition of the true inactive carriers, and with increasing biomarkers alongside also the staging of liver disease, that really to tease out that subgroup that truly will not progress, and differentiating those from who clearly would benefit from treatment. Thank you.
Thank you, Philippa. I appreciate your joining the Apostle webinar, and we do hope we would be able to have you sometime again in near future. We must congratulate you and the WHO team for the new guidelines. I'll now pass over to Professor George Lau, and I would like to be recused for some other clinical commitments. And thank you, George.
Yes.
And very nice that you chose this topic. Thank you. Over to you now.
Thank you, Sari. Well, we would like to move on to our next topic going to be presented today. And the title is The Global Trends and Regional Differences in the Incidence and Mortality of Hepatitis A from 1990 to 2019 and its implications for preventions. And the presenter was Dr. Gao Guiying, also from Beijing. She works at the Department of Epidemiology and Biostatistics. And we would like to hear her findings at this point. Dr. Chao, could you?
Thank you, Mr. Chairman, for your gracious introduction. I am honored to have a chance to share our research on this special occasion. The title of our research is The Global Trends and Regional Differences in hepatitis A and of hepatitis A from 1990 to 2019 and implications for its prevention. The outline of my talk as follows. The first part, I want to introduce the background of this research. The second part, I introduce the methods of this research. The third part covers the main results. And then I propose the advantages and the limitations. Finally, the summary findings are given. Hepatitis A is an inflammation of liver caused by the hepatitis A virus, HAV. This virus was firstly identified by Feldstone and colleagues in 1973. HAV is transmitted through ingestion of contaminated food and water, or through direct contact with an infectious person. Hepatitis A occurs sporadically and in epidemics worldwide, with a tendency for cyclical recurrence. An estimated more than 100 million HAV infections cause approximately 1.5 million clinical cases of hepatitis A each year worldwide. A safe and effective vaccine is available to prevent hepatitis A. In addition to the introduction of hepatitis A vaccine, decades of improved sanitation and hygiene measures contributed to combat hepatitis A. Usually, the sanitary conditions and hygienic practices were good in high-income countries, but still poor in low and middle-income countries. However, hepatitis A outbreaks frequently occurred in countries regardless of their income in recent years. For example, imported frozen produce items and infected travelers from endemic regions are associated with hepatitis A outbreaks in high-income countries. Frequent international trips and travels in middle-income countries play important roles in outbreaks of hepatitis A and global transmissions of HIV. For low-income countries, the endemicity levels of hepatitis A are still high due to poor sanitary conditions and hygienic practices. Thus, the prevention of hepatitis A is facing more and more complex situations, especially with globalization's processes. Therefore, our study aimed to assess the tempo trends in incidence and mortality of hepatitis A at global, regional, and national levels from 1990 to 2019 to provide a more comprehensive perspective in the design of targeted strategies in hepatitis A prevention tolerated to different countries. In this research, we extracted data on annual incident cases, deaths, age-standardized incidence rates, ASIRS, and age-standardized mortality rates, ASMRS, of hepatitis A from 1990 to 2019 by sex, age, and location from the Global Burden of Diseases GBD Study 2019. These data were available from a total of 204 countries and territories, and these were categorized into 5 regions in terms of social-demographic index SDI and 21 GBD regions according to geographic contiguity. We calculated the percentage changes in hepatitis A incident cases and deaths, as well as the estimated annual percentage changes EAPCS of hepatitis of ASIRS and ASMRS between 1990 and 2019 to quantify the trends in incidence and mortality of hepatitis A. In addition, we explored the correlation between EAPC and ASIR in 1990, as well as SDI values in 2019 in different countries and territories by Pearson correlation analysis. At the global level, the number of hepatitis A incident cases increased by 30.9% from 139.54 million in 1990 to 158.94 million in 2019, whereas the number of hepatitis A deaths decreased by 63.61% from 10.79 thousand in 1990 to 3.93 thousand in 2019. The overall ASIR of hepatitis A remained stable between 1990 and 2019. The overall ASMR of hepatitis A decreased from 2.07 per 100,000 in 1990 to 0.52 per 100,000 in 2019. At the national level, the two countries with the most pronounced increase of hepatitis A incident cases from 1990 to 2019 were Qatar and Afghanistan. The country with the most pronounced decrease of hepatitis A incident cases from 1990 to 2019 was Bosnia and Herzegovina. The ASIR were deemed in an increasing trend in 98 countries or territories between 1990 and 2019, with the largest increase in Thailand. The ASIRS deemed in a decreasing trend in 68 countries or territories between 1990 and 2019, with the largest decrease in Belarus, followed by Argentina. The remaining 38 countries or territories showed a stable trend in ASIRS between 1990 and 2019, such as the USA, Mexico, and Singapore. This figure shows the EAPC in ASIRS of hepatitis A between 1990 and 2019 across SDI and GBD regions.
We cannot hear you. We cannot hear you.
Hello? Hello, can you hear me?
Maria, yes, so nice to see you. We are in the middle of the presentation. Our Beijing colleagues is presenting the global trends on hepatitis A worldwide. So Dr. Chow, can you come back in? It was interrupted. Dr. Chow? Yes, please. Dr. Chow, please share the screen again. Very good. So Dr. Chow, can you? We cannot hear you, Dr. Chow. Dr. Chow, can you put the screen back with the share screen and try to improve the your voice? We cannot hear you. The audio. It's interrupted. Ishumi, can you work on it? Maybe Maria, are you coming in? Yes, Ishumi, what's happened?
Yeah, this is
Can Dr. Chow start this? Yes, Dr.
Yeah.
Chow, are you with us?
Dr. Chow, would you please check your microphone? The audio? No, sir. No, ma'am.
No, we cannot
the
hear you.
chat.
No, we can only see your words on the chat. Dr. Chow, can you check your microphone and improve the audio?
Hi, to me, could you please give me Dr. Chow's cell phone number? I can call her.
Yes, I just know the normal phone number, and then
Okay, I just please send to my WeChat, please.
it's 86
Yeah, I have called her. Okay.
183
Okay. Yes.
2858 1641. I said the
Excuse me, could you send a number to my WeChat?
Yeah, just send the chat. Don't spell it out. Okay. If that is the case, maybe shall we move on to the next one instead and try to compensate?
Yes, she's out of the line now, and then maybe she'll be coming back. So, how do we do, sir? Oh, yes.
She is starting the screen.
Yes, sir.
Yes, Dr. Chow, are you with us?
Mm.
哎，您好，我是未来。现在我 Bila 上听不到您的声音了。那要不您再 check 一下麦克风，把声音调一调。对。OK，谢谢。Hi, Professor Law. I called Dr. Chow and Dr. will withdraw. Then we start again. We intro again.
Okay, all right.
Okay, thank you.
Yeah, because of the time constraint, shall we move on to the third presentations instead? And well, the third talk is actually on hepatitis C, and I think that the best persons to moderate the session is Professor Wei Lai here with us, the king of hepatitis C in our country. And Professor Wei Lai, can you take over this? This paper is will be presented by our Taiwan colleagues, Dr. Liao Zhonghua from the Professor Gao Jiaxiong group. Yes, Professor.
Okay, Professor Lau.
Yes.
So it's my great honor to invite Professor Liu and from the National Taiwan University and the Professor Gao Jiahong's team. The title is the safest way pathway for patients with chronic hepatitis C virus infection and the compensated liver disease. A real-world data in Taiwan. So, please, Dr. Liu.
Okay, thank you. So, Good evening, ladies and gentlemen. And first and foremost, I would like to express my gratitude to Professor Wei for the kind introduction. And secondly, I would like to extend my thanks to HAPATO for providing me with the opportunity to share our work. And chronic hepatitis C virus infection stands as the primary culprits of cirrhosis, SCC, and hepatic decompensation. And globally, the prevalence of HCV infection is about 0.7%, with approximately 57 million individuals grappling with this virus. And persistent HCV viremia heighten the risk of diverse hepatic and extrahepatic manifestation, significantly impacting patients' mobility and mortalities. And conversely, the implementation of effective antiviral therapies leads to substantial enhancement in health-related outcomes. Indirect antiviral agents with pan-genotypic potency are recommended as the first-line therapies due to their ability to simplify care by eliminating the need of HCV genotyping test and intense on-treatment monitoring. Among these agents, Sofwell offers additional advantages, including a fixed-dose combination formulation that is unaffected by food intake, a fixed treatment duration of 12 weeks, pan-fibrotic activity, and few potential drug-drug interactions. And the efficacy of Sofwell has been well established in global astro trials, demonstrating an overall SBR12 rate exceeding 95%. And furthermore, the Asian phase 3 trial, which is conducted by Professor Wei, confers excellent treatment responses with the exception of HCV genotype 3b infections. And subsequently, the global approval of Sofwell, a meta-analysis encompasses more than 5,000 patients treated with Sofwell, drawn from 12 real-world cohort studies conducted in the United States, Canada, and Europe, unveiled an SBR12 rate of 92.6% among those who received at least one dose of treatment. By excluding patients with non-biological failures, an impressive of 99% of them attained SBR12, and furthermore, the response rate remained unaffected by HCV genotype or the stage of liver fibrosis. And prior to the publication of the study, there was a scarcity of data regarding to the real-world effectiveness and safety of Sofwell for East Asian patients. Consequently, we undertook a large-scale multi-center study to evaluate the performance of Sofwell for 12 weeks in patients with compensated HCV infections in Taiwan. And between July 2019 and March 2020, we retrospectively enrolled eligible patients at 15 academic centers in Taiwan. A patient were considered for inclusion if they had compensated HCV infections, aged 20 years or more, and received Sofwell treatment for 12 weeks. Prior to treatment initiation, we collect patient demographic and comprehensive array of laboratory data as shown in the slides. Additionally, we calculate the FIB-4 and APRI score for all patients, with a FIB-4 score more than 2.25, indicating a fibrosis stage of F3 or more, and those with concomitant APRI score of more than 10, indicating F4 fibrosis. And lastly, we also assess the hepatic imaging study, including ultrasound, CT scan, and MRI studies to detect SCC or signs of liver decompensations. And patients included in the study receive Sofwell fixed-dose combination 1 tablets per day for 12 weeks. And after treatment initiation, they underwent monitoring at on-treatment week 4, 8, and 12, and off-treatment week 12 for laboratory testings, drug adherence, and safety, as shown below. And the viral loads at the end of treatment and off treatment week 12 were reported. The endpoint of the study was the effectiveness of antiviral responses, including evaluable population among patients receiving at least one dose of treatment and per protocol population among patients with SBR12 reports. And we'll also report the safety profiles, including premature treatment discontinuation, serious adverse event, and common adverse event of 10% or more, a proportion of grade 2 or more bilirubin and ALT level elevations, and eGFR change before and after treatment. And here is the follow-up study. Among the 1,880 patients enrolled in study, 98.9% completed a full course of treatment, and additionally, 96.3% complete 12 weeks of treatment follow-ups. In terms of baseline characteristics, about half of patients were aged more than 60 years in males. About 93% of them had not undergone prior treatment. The majority of patients were infected with genotype 1b and 2, and about 80% exhibit a fibrosis stage of F0 to F2 and a CKD stage of 1 or 2. In turn, at the end of treatment, 99.7% of patients showed undetectable serum SCV RNA levels. In the intention to treat analysis, 95.6% of patients achieve SBR12. Additionally, in the per protocol analysis, 99.3% of patients attain SBR12, and only 13% experience true biological failures. And we conduct a subgroup analysis which reveal a consistent SBR12 rate across various host and viral factors, including age, sex, prior treatment history, renal function, stage of liver fibrosis, HCV RNA levels, and SCV genotypes. In terms of safety, only 0.2% of patients discontinue treatment due to treatment-emergent adverse events, while 2.3% of patients experience serious adverse events during treatment. None of these patients were deemed related to software treatment. And common adverse events including headache, fatigue, nausea, and insomnia, but all of which were of mild grade. A small percentage of patients experienced grade 3 elevation in total bilirubin and ALT levels, respectively, but none of them developed liver decompensation during the study period. And lastly, in terms of renal safety, we observe improvement in eGFR among patients with CKD stage 3 to 5, stability among those with CKD stage 2, and a mild decrease among patients with CKD stage 1. These findings are particularly relevant for patients with advanced CKD stage, demonstrating excellent renal safety with the use of full-dose software treatment. And while the study provides robust evidence of the excellent performance of software in East Asians, several limitations should be acknowledged. These include a limited number of patients with SCV genotype 4 and 5 infections, the absence of archive samples to assess the effect of RAS on SBR12, and insufficient information about SCV genotype 3 subtypes to confirm the influence of on effectiveness, and the absence of standardized adverse event report form, which might introduce biases. And finally, in summary, this large-scale real-world study demonstrates that software for 12 weeks is efficacious and well-tolerated for chronic SCV infected patients without cirrhosis or a patient with composite cirrhosis in East Asians. And finally, I extend my sincere gratitude to all the patients and collaborators who contribute to this study. And thank you for your attention.
Thank you, Professor Liao. Very last statement. So any comments from the audience? Hi, Professor Liu.
Yeah.
Very nice to see you again online.
Yeah, a good friend.
So, dear Philippa, any comments?
I think that's based on the excellent performance of software in East Asia. I think that's the next step is to eliminate the virus as soon as possible, as proposed by the WHO. So by mass screening and early link to the care, so use the very effective and safe agent, we could eliminate the virus as soon as possible. Okay, this is my comment.
So let's
Can I
move
make
to
a comment?
hi, Philippa, please.
Yes.
Yeah, I think it's very nice to see that the results are very similar between Asian patients and European patients. Sorry, Philippa, I haven't seen you, but I think the study confirms the safety and efficacy profile in other populations. Thanks for the presentation.
Oh, thank you, Maria. So, Philippa?
Yes, just to add my comments, it's great to see this data. I think we're all aware there's a need for clarity on strategies for management of treatment failure, and especially in low and middle income countries. I think 2 points to emphasize. Clearly, this regimen is highly effective. I think two key points: the need for the SVR to be done, because there's been an increasing tendency for SVR not to be done. So we're unaware when persons have failed treatment. And while this may not be a problem in low prevalence settings, in high burden countries, Egypt, Pakistan, or in high risk populations, even a few % treatment failures can really contribute to ongoing transmission. So I think that's one key point. Something that wasn't clear in this paper were the reasons for treatment failure. Certainly in some cohorts from low and middle income countries, that unrecognized cirrhosis and therefore short durations of treatment may have been a contributing factor. And I think the final point is Sofel-Vox, obviously a highly effective regimen, increasingly and widely used for management of treatment failure, but it's not clear whether retreatment with the same pan-genotypic regimen would have achieved a comparable outcome. And certainly in Egypt, in cohorts we'd worked with, retreatment with SOF-DAC achieved SVR in those with treatment failure in the vast majority. So I think there's a need for more comparator studies on the strategies for treatment failure and a full assessment of likely reasons for treatment failure, particularly with unrecognized cirrhosis and suboptimal treatment of those. Thank you.
Thank you very much. And Dr. Chow is come back. So let's move back to Dr. Chow.
Can you hear me?
Yeah, yes. And I don't think you can go from the very beginning. Just in the start from and the last time cessation. Last time stop it. You can restart from the last slide. Yeah, go.
Okay.
Show your screen. Yeah.
Can I share my experience in the treatment of hepatitis C in Myanmar?
Okay. Dr. Shaw, moment, please.
Myanmar.
Okay.
In Myanmar, we use sulfosylphosphatidyl palatasvir plus ribavirin. That will lead to achievement of SVR in 99.99%, almost 100% cure, irrespective of all the genotypes. One may argue, why add the ribavirin? As far as our experience concerned, we do not encounter any serious complication due to the ribavirin. So by addition of there are unrecognized cirrhosis, particularly in the villages, in the rural area. So we add ribavirin to the esophageal ballotosphere so that there'll be very little amount of resistant cases, and we don't have to spend expensive drugs like a solver box. So our Myanmar GI and Liver Society recommend treatment of solver phosphobalatosphere plus ribavirin in the treatment of chronic hepatitis C. That is our experience.
Okay, thank you, Professor King. Thank you for you and the sharing in the Miami experience. So let's restart by Professor Dr. Chow. Dr. Chow.
Okay, I can hear you.
Okay.
I started with this page. This page.
Yeah. Okay. Sure. Go ahead, please. Full screen, please.
Okay. I started with the results of this study. At the global level, the number of hepatitis A incident cases increased by 30.9%.
Please, yours full screening. Full screen. 请全屏显示 full screen.
Okay. At the global level, the number of hepatitis A incident cases increased by 30.9% from 139.554 million in 1990 to 158.94 million in 2019, whereas the numbers of hepatitis A deaths decreased by 63.61% from 10.779,000 in 1990 to 3.93,000 in 2019. The overall ASIR of hepatitis A remained stable between 1990 and 2019. The overall ASMR of hepatitis A decreased between 1990 and 2019. At the global level, the two countries with the most pronounced increase of hepatitis A incident cases from 1990 to 2019 were Qatar and Afghanistan. The country with the most pronounced decrease of hepatitis A incident cases from 1990 to 2019 was Bosnia and Herzegovina. The ASIR deemed in an increasing trend in 98 countries or territories between 1919 and 2019, with the largest increase in Thailand. The ASIR were deemed in a decreasing trend in 68 countries or territories between 1990 and 2019, with the highest decrease in Belarus, followed by Argentina. The remaining 38 countries or territories showed a stable trend in ASIRS between 1990 and 2019, such as the USA, Mexico, and Singapore. This figure shows the EAPC in ASIRS of hepatitis A between 1990 to 2019 across SDI and GBD regions. For the SDI regions, there was an increased trend in ASIRS of hepatitis A in low and low-middle SDI regions, a decreasing trend in middle and middle-high SDI region, and a stable trend in high SDI region. For GDB regions, there is an increasing trend in 7 GBD regions, such as high-income Asia Pacific, Oceania, and Australasia, a decreasing trend in 10 GBD regions, such as Central Asia, East Asia, and Southeast Asia, and a stable trend in Western Europe, Central Latin America, North Africa, and the Middle East, and Western Sub-Saharan Africa. We observed a decreasing trend in ASMRS of hepatitis A in all 5 SDI regions and 21 GBD regions between 1990 and 2019. The results of Pearson correlation analysis found a significant negative correlation between EAPC and ASIR in 1990, a significant pointed correlation between EAPC and SDI value in 2019 for the countries and territories with SDI value higher than 0.7, and a significant negative correlation between EAPC and SDI value in for countries and territories with SDI value less than 0.7. There are two advantages of our research. First, the global landscape, long-term and regional differences in incidence and mortality of hepatitis A were assessed using a post-hoc analysis of data from the GBD study 2019. In addition, this study provided a comprehensive perspective in the design of targeted strategies in hepatitis A prevention and tolerated to different countries. However, two limitations in this study should also be acknowledged. First, the accuracy and the robustness of GDP estimates largely depend on the quality and the quantity of data used in the modeling. Second, due to the GBD study taking the country as its basic unit, the incidence and mortality of hepatitis A might be a margin of bias in countries in lack of national systematic surveillance and population-based studies of hepatitis A. The final part is the summary findings of our research. There is an unfavorable trend in ASIR of hepatitis A that it is still pending in hyperendemic regions and is emerging in low endemic regions globally. Due to the rapid globalization processes and increased high-risk populations of hepatitis A, the number of hepatitis A cases is probably in an increasing trend, posing novel challenging for eliminating these diseases, especially in high-income regions. More targeted and specific strategies were needed to eliminate hepatitis A, such as sanitation measures and comprehensive plan for surveillance and vaccination against hepatitis A. Future studies focusing on targeted prevention and control strategies for hepatitis A were warranted. That's all of my share. Thank you.
Thank you so much. This is Dr.
Professor
Omata. I just joined. Sorry about
okay,
Dr. Kao.
Okay, good.
Thank you very much. Wonderful talk. I just joined, so please, Dr. Wei Lai, do the moderations if there is any questions.
Yeah, Professor Omata. You have any comments and otherwise?
Well, I think in their country, hepatitis A is just like presented is still a big problem. But how about hepatitis E virus infection? Because they are both similar acute hepatitis cause. So another virus, hepatitis E virus, acute hepatitis. What's the current situation in China? HEV.
Yeah, HEV, yeah. So, Dr. Cao, can you answer the Professor Omata's question?
Dr. Kao, could you answer that?
Dr. Cao? Cao医生能回答一下吗? Okay, so let me give a brief answer of Professor Omata. And in China, the hepatitis E surveillance is in few of the local area, slaughter and as A and the Soviet. And however, you can find some special population, and particularly in the water product worker, and also they found some the patients in Erde, and in particular in Xinjiang, in the west area of China, and also in the seaside and the city, such as some city in Shandong province. So it seems that it's connected with the water pollution. And however, hepatitis E and the vaccine works very, very good. So therefore, for this and the populations, the local government suggests the vaccination for this and the high-risk populations. And meanwhile, in addition to this, the local prevalence data, and the hepatitis E and occurred in elderly population may be induced in high mortality, and also and the induced high mortality in pregnant women. So therefore, in this kind of population, and also in the vaccination and targeted population, it's something in China for HEV infection. Thank you. And also the other one is the HEV genotyping is different from in the Western country. And then meanwhile, recently, we also can see some chronic hepatitis C virus infection. The chronic HEV infection defined here as an HEV infection longer more than 3 to 6 months. And this kind of patients occurred in the transplant patient population, including in the bone marrow transplantation and kidney transplantation and liver transplantation patients. Maybe due to the immunoinhibitor agents used. So and currently it seems effective treatment is the ribavirin. However, we have the patients for more than 6 months treatment duration, and then we can and test the hepatitis Z and the RNA switch to lactive in store. So and in our clinical practice, and the recurrence rate is very, very low. So therefore, I think for chronic HCV infection, we can and the treat use the ribavirin. And actually, we also use the in the sulfasvir because the HEV sequence has a similar sequence with the HEV and the HCV. And however, sulfasvir and the fair to treatment. So ribavirin is good. Also, ribavirin is cheap. And thank you, Professor.
Well, that's exciting data you are, showing us and then telling us. So maybe next year in your meeting, we got to deal about the hepatitis A virus and the HIV since 2019. Dr. Kao
very good
gave a wonderful talk on this subject until 2019, but maybe we have to update from 2019. Thank you very much.
Thank you so much, Professor Mata. I can see the Diana and the Philippa raise hands. So Diana, could you go ahead, please? And excuse me, Philippa, you the second. Can you? Okay, please.
Hi, Professor. Let me congratulate our speaker for viral hepatitis A. We know that there's a vaccine. I was just wondering whether your vaccination rates have gone down, and is it going down after the COVID, or it's remained stable even during COVID? Number two is, even if the rates are increasing, mortality is actually decreasing. So can you explain it from your end, what has been done to alleviate the increasing prevalence, but yet the mortality of these patients with viral hepatitis A has decreased? So are we seeing less severe cases of viral hepatitis A? Thank you.
Hi, Professor Liu.
Sure. Yeah, I'm here.
Can you, in the response to Professor Diana Payama?
I heard that Professor
Viral hepatitis A.
Focus on A, not C.
So it's Professor Dr. Kao.
So Professor Payawa, you mentioned
maybe you can
hepatitis
answer. It's
A.
about just the vaccination program in hepatitis A in your country, Professor.
Yeah. Sorry, I'm in airport. Not very clear. So could you briefly your question, please?
We know that there's a vaccination program already for viral hepatitis A. I was just wondering whether there is a problem in your vaccination program for viral hepatitis A, because apparently in our country, that's what we do right now, activate the vaccination program to control viral hepatitis A. So is the prevalence, increasing prevalence related to a vaccination failure in these countries?
Okay, thank you. And the vaccination about hepatitis E very effective, and also the safety profile is good. And however, and we keep the hepatitis A vaccination to the pretty young and children. And however, hepatitis E is not so popular because the hepatitis E prevalence just in some local area. So just in this local area, we keep the HEV vaccination. Thank you. So,
Thank you.
So Easterbrook, Dr. Easterbrook, Philippa? Okay.
Yeah. Yes. So I think this is a very timely paper commenting on some of the changing epidemiology. I think it is important to emphasize that, you know, one of the key messages was that population growth in low and middle income countries it has been a key driver for the overall increased incidence, and it's noteworthy that China and India accounted for 1/3 of the cases, and that overall there's a declining incidence in those countries with rising socioeconomic levels and improved hygiene practices. But I just wanted to flag the issue of vaccination policy. So the WHO recommends that in highly endemic countries, that large-scale vaccination is not routinely recommended. And in low and very low endemic settings, it really is focused on targeted vaccination of high-risk groups. So for example, in Europe, we've had quite a number of outbreaks across Europe among men who have sex with men. And so that targeted vaccination of those groups. And where the challenge is now going forward in terms of vaccination policy is in those countries moving from high to intermediate hepatitis A endemicity, where there is a significant proportion of the adolescent and the young adult population where you haven't been vaccinating and where there's declining incidence who may be susceptible. And this is where each country needs to make a decision about whether a large-scale vaccination in early childhood would be cost-effective, as well as catch-up vaccination. So I think it's just flagging some of the challenges in decision-making as we move from high endemicity to intermediate, and particularly with the subgroup of the middle classes who are the ones that are experiencing the biggest reduction in incident but will be at risk. So it's an interesting debate going forward, and each country will evolve its own vaccination strategy. Thank you.
Thank you, Philippa. And dear Professor Marta.
Professor Lewy. Professor Lewy.
Okay.
Professor Lewy.
Yeah.
Can I talk about the history of hepatitis A? 1 minute.
Okay.
It's been mentioned that everybody knows hepatitis A was discovered by the Flintstone. Flintstone is, in fact, postdoc student.
Excuse me. Excuse me. Dr. Bean? Professor Wien? Professor Wien?
Can
We can't hear you.
Hello, can you cannot hear me?
Yeah. Okay.
I was talking about the history of hepatitis A, started by Saul Crewman, who did person-to-person infection in the mentally handicapped patients institution. Then the Saul Crewman produced MS1 and MS2 strain, and he did a study in the Lautier prison. In the voluntary prisoners were transmitted from one to another. That's what I would like to find out. They have done, I know I'm old enough to have met the Saul Crewman, and the hepatitis A studies were done by Robert Bassel, but they did person-to-person transmissions in the mentally handicapped institution and in the prisoners. That's all. Can you hear me?
Yeah, some.
Okay,
So,
Mongolia, just one comment, okay?
yeah, please.
Okay, thank you. Professor Batar from Mongolia, and my comment is just the most effective prevention of against hepatitis A virus is specific immunization. For example, in Mongolia had very high prevalence and incidence of rate of hepatitis A virus before immunization, before introduction of hepatitis A virus immunization in 2012. For example, in 2011, incidence of hepatitis A virus was about 50,000 cases for Mongolia. We introduced hepatitis A virus vaccination for children and in 2012, and incidence in 2014 has decreased 50% of cases about hepatitis A virus. Also, in our country is in 2020, the vaccine against hepatitis A virus is mandatory for children aged 6 months to 16 years, for children aged 6 months. Also, in our country, national hepatitis A vaccine coverage among the children was 93.9% up 1 year old. Also, in our country, routine vaccination program introduced end of 2021. So is in my comment is specific immunization for hepatitis A virus is very effective. Okay, thank you.
Okay, thank you. Professor Omata?
Yes, I'm here.
Yeah, do you have any further comments and otherwise?
No, I don't have a comment, but I think as was mentioned, maybe vaccination program may vary from country to country. Especially by the economic situation as was commented. So maybe we have to discuss in the Asian Pacific region next meeting in the Beijing or in the single topic conferences.
We will organize this session in HAPATO 2025.
Right.
Okay, so dear Professor Mata, ladies and gentlemen, because we already in the behind the schedule, so I want to close in today's webinar. And thank you for all three speakers and the panel. And thank you for your very nice talk, and so you very and the value about the comments and suggestions, and in particular it seems in the everybody interested for hepatitis E, and the Professor Omata already, and otherwise we are having a special session for that. and maybe we have the end in next year and in Beijing. And so welcome to HAPATO 2025 in Beijing. And thank you for the Professor Duan, and Professor Liu, and Professor Hao for your very nice talk. And thank you for the comments from everybody. Thank you and have a very nice weekend.
Yeah, everybody, have a nice weekend. See you soon. Thank you. Bye-bye.
Thank you. Bye-bye.
Okay, bye. Bye.
Thank you.
Thank you.